Hi everyone, I'm Dr. Deed Harrison of Chiropractic BioPhysics Technique and Chiropractic BioPhysics nonprofit, our Spine Research Foundation. This week's CBP nonprofit research video review comes from a paper in 2005 in the European Spine Journal. The posture of the thoracic spine will intimately affect intervertebral disc loading and stress concentrations. This project details one of the important components of altered posture of the thoracic spine and its influence on disc loads. The title of the paper is Anterior Thoracic Posture Increases Thoracolumbar Disc Loading by myself, Dr. Deed Harrison, lead author, my good colleague and great friend, Dr. Chris Kaloka, my late father, Dr. Donald Harrison, my father's former PhD advisor, Dr. Tad Yannick, my good friend, Dr. Jason Haas, and then the late Dr. Tony Keller. Unfortunately, a couple of the authors have passed on since this project, which is part of life, unfortunately. The project was published in European Spine Journal 2005, volume 14, page 234 through 242. Of interest, just a brief introduction. Originally, in the past, it was assumed that disc degeneration was quite normal. The problem is it does occur in almost every single person's spine as we age. However, to call it normal is not necessarily appropriate. The reality of it is disc degeneration can turn into disc disease, which can cause and accentuate back pain. It can lead to a cascade of problems like spine stenosis eventually over time as the disc degenerates and deforms and is not able to transmit loads effectively from one vertebra to the next. We get stress concentrations, and then we get bone spurs that lead to stenosis, etc. So to say degeneration of the disc is actually normal is quite a misnomer. For example, just a quick study that was done on disc degeneration in 1999 by Solomon, and this was in Spine in 1999, and the reality of it is disc degeneration early on in childhood affects back pain not only in childhood but later into the adult years in these same children. This is a prospective longitudinal study that shows early disc degeneration is contributed to and causing low back pain as we get older. So if we see disc degeneration, it's a problem. In reality, in the absence of external forces and loads, the biggest contribution to disc compressive loading and or shear loading is in fact muscle activity, muscle loads. Well, what accentuates or increases muscle load is not only things that you're holding and lifting with your body, but in fact it's the body position at the time that you're doing this loading. So body posture and the alignment of the spine will intimately affect disc loading via its effect on not only the alignment of the segments, but also on its effect on muscle activity. This particular project in 2005, at the time, there was not a lot of papers on this topic, how positions or postures of the thoracolumbar spine influence and contribute to disc mechanical loading. One of the first projects that was done on this topic in detail with a proper spine model at the time was 1998. This came out in the European Spine Journal by Kiefer et al. And what they did is they developed a fixed model of the rib cage. So the rib cage itself was not flexible in this model. So we know from previous studies that we've done, and we know today, that the thoracic spine will straighten out its thoracic kyphosis, and there's movement, flexion and extension of the thoracic spine when you translate the rib cage forward or backwards. That was not modeled in this in this 1998 background project. What they did is they called this a rigid object, and they translated the rib cage forward and backwards relative to S1. The reality of it is they used T1 and translated the entire rib cage forward at T1, and this was a rigid area, and then they looked at the displacement relative to S1, and they looked at things like what are the compressive loads in newtons acting on the L5S1 disc. And of note, if you look at their peak displacement here, the peak displacement is almost 40 millimeters anterior, and then almost 40 millimeters backwards. Anteriorly, they get 550 newtons of increased compressive load, relative to the neutral alignment of the thoracic spine. Now, neutral alignment is where T1 would sit right over S1. It would be right along this y-axis. T1 sits over S1. So this area sits over S1. Now, what does 550 newtons translate to? Well, that's roughly 56.1 kilograms of compressive load or compressive force. And then you can see it goes up to almost 600 newtons when I go backwards or posterior. So this was the background study by Kiefer et al. Well, what does compressive load have to do with disc degeneration? Well, we know this: sustained increases in compressive loading on the disc will trigger the production of things like matrix metalloproteinases in the intervertebral disc. Now, matrix metalloproteinases, they are catabolic in their function. They start to degrade or break down disc tissue. They also will trigger inflammatory reactions and will excite inflammatory reagents, and they may in fact trigger the production or enhance the production of substance P, which then increases pain out of the nerve receptors or your experience of pain. So we know that increases in compressive loading on the disc, when they're sustained and they're higher than normal, that's going to cause problems. It's going to accentuate disc degradation, inflammation, and then consequently likely pain in people. Now, that particular project, there's a great one on compressive loading in the disc that came out in Spine in 2003. So this is not new information, but it is of interest. So we are interested in how positions of the thoracolumbar spine in normal healthy subjects, how those will influence thoracolumbar erector spinae muscle activity, how that will then increase or maybe not intervertebral disc compressive loads. Okay, so this is the purpose of this particular project. Thus, the relationship between trunk position and posture, spine geometry, extensor muscle load, and the consequent loads and stresses acting on the IVD, intervertebral disc, is not really well understood at the time of this project. And in fact, there's still research ongoing in this particular field 12 years later. The objective of the current study is to characterize changes in thoracolumbar disc loads and extensor muscle loads following anterior thoracic translation in healthy men and women. Now, the uniqueness of this particular project is we chose upright stance and we physically x-rayed live subjects in a neutral position and an anterior translated position. We then programmed in a validated model the change in the vertebral body coordinates. So we're not just modeling the rib cage as a rigid object like the 1998 project by Kiefer et al. In European Spine Journal. This is the reality of what the human spine would do with an anterior translation posture. Okay, so the methods of this particular project. We digitized the vertebral body coordinates from C2 to S1 and the location of the femoral head and acetabulum area by taking full spine lateral x-rays in the upright position of 13 men and 5 women. We did 2 standing lateral full spine x-ray views, a neutral or true neutral lateral, and then an anterior translation of the rib cage where the subject was asked to maximally translate their rib cage while attempting to keep T1 vertically aligned with T12. And we've modeled or we've assessed this to see how close these subjects maintained a vertical alignment of T1 over T12 relative to the bottom of the spine at S1. So we can see, are they truly creating flexion, extension, how much, etc. Then what we did is we put this into a thoracolumbar sagittal plane model that has been validated for deformity progression, for intervertebral disc diurnal changes, which means how compressive loads throughout the day will cause a shrinking in their intervertebral disc as fluid flows out, etc. So we have a validated model in the sagittal plane. This model was used to estimate extensor muscle loads, compressive and shear stresses acting on the discs, and this was calculated for both the neutral and the anterior thoracic translated position. B shows the neutral alignment, where the thoracic spine is lined up with the hip acetabulum. So this is what we'd call classic neutral posture of the subject. Then in A, this shows maximum anterior translation for one of the female subjects. You can see that T1 is attempted to be maintained over T12, and those are both in front of the hip and acetabulum. So we took two static x-rays, one in neutral and one in maximum anterior translation. So while we created movement of the trunk, the x-ray itself is not a movement x-ray, it's an in-position x-ray. And we did do maximum, we did not do in between, percentages of maximum. Like, for example, the 1998 paper that we just looked at by Kiefer et al., what they did is they did about 40 millimeters anterior. So we'll have to see how far our subjects can translate relative to that. So here's this sagittal plane model that was developed. This model was developed at the University of Vermont by the late Dr. Tony Keller, professor of mechanical engineering there. He and his graduate students developed this model to look at different things in the spine, and it's a model of the sagittal plane of C2 relative to S1. And then here's the physical components of the model, where we look at what's called line of gravity, body weight. This is the vertebral body centroid here, called C. And then this is the lever arm anterior relative to the center of the vertebral body, or the disc. And this is the lever arm posterior from the centroid over to the posterior aspect. And then E would be the extensor muscle loads. And then we have the lever arm LE, which is basically the averaged extensor muscle load relative to the centroid of the intervertebral disc or of the intervertebral body. And then here's the engineering equations if you want to look at that now. These are quite complex to me. I'm not a PhD in mechanical engineering. Now, I know what these things mean, but for me, I'm not going to be solving these equations. Those were done by Professor Keller and his graduate students, and that's all in background work and other papers that you can look up if you read this paper. So for me, I'm a clinician. I don't have a degree in mechanical engineering, so I'm not going to be able to, I'm not processing these equations. We have a computer system that does that. Results. The subjects were able to translate forward the following amounts. If I looked at C7, the vertebral body C7, the lower neck, relative to the hip axis, how far could subjects translate forward? 101.5 millimeters. Now, in the Kiefer et al. Study, they used T1 to S1, which is pretty close to the second one here, C7 to S1. We did 81.5 millimeters anterior as an average in these 18 subjects, 13 men, 5 women. That's approximately double of what Kiefer et al. Found, approximately double, okay? And so you'll see that translates into different results. Kiefer et al. Did 40 millimeters. We found in live subjects they could translate about double that, 81 millimeters, C7 to S1. And then if we look at T12 to S1, so T12 to S1, these subjects, 18 subjects in this project, translated forward 58.9 millimeters. Okay, that's T12 to S1, 58.9 millimeters. Okay, so we have significant anterior shift in these normal healthy subjects. Anterior translated posture, disc loads, and stresses were all increased for levels below T9. There were transient changes up above T9, but consistently the levels below T9, the translated forward posture increased all the disc loads, all the disc stresses below T9. Increases in IVD, intervertebral disc compressive loads, and shear loads were most significant or the largest at the L5-S1 and the L3-L4 levels. Now that makes sense. L3-L4 is classically the apex of the curve, and then L5-S1 is the bottom of the spine, where I'm now shifting from the low back down to the sacrum. So it makes sense at those points we should see the largest increases in loads. The extensor muscle loads required to maintain static equilibrium in this upright postural shift increased by 147 newtons in the neutral position to 667 newtons in the anterior translated position. Now that's huge. You look at that. That is roughly 4 times. So we're seeing a 4.5 times increase in the extensor muscle loads required to maintain static equilibrium when I go from neutral to anterior translation. Now you can just do this yourself and feel it. You can take your thumbs and stick them in your mid-lumbar spine and hold your body in a neutral position and then shift your rib cage forward. You'll feel an increase in the tension or tightness in the extensor muscles down in the mid-lumbar spine and the lower lumbar spine. This study shows here that their load increased by 4.5 times. Now, what does that mean for people with disc loads and back pain? Well, let's talk about that. Okay. First of all, the amount of horizontal offset per segment is shown here. This is neutral relative to maximum anterior translation. You can see all the segments translated significantly forward. And what I'm most interested in this one is T12 versus T1. How close are they? Well, you can see that T1 goes a little bit further forward than T12. And what's a little bit? Well, when I break it down, it's about 20 millimeters. So the average subject, it's really difficult to maintain a true neutral translation. You're going to flex forward just a tiny bit in the thoracic spine. That's part of the natural movement of the rib cage. So we do get a little bit of what we call a flexion angle of the top of the trunk relative to the bottom, but we're still seeing that the bottom of the spine, or bottom of the thoracic spine, T12, is translating significantly forward relative to S1, and it's doing it at about 60 millimeters compared to T1 being about 80 millimeters. So the extensor muscle loads, this is graphing the kilogram of load on the extensor muscles at different levels. So you can see at T9 we see the biggest change. So the diamonds represent the neutral position of the spine, and then the squares represent the increase in extensor muscle load when we translate forward. You can see the biggest load increase is in fact at L5S1. So we're seeing that extensor muscle load goes from about 15 kilograms, it jumps up to the upper 60s. Now that's a huge change in the extensor muscle loads. Think about that. That's 4.5 times the muscle load required to maintain stability when your trunk's translated forward. Now that right there should just go boom. That's a huge part of this study. So often I argue with people and it frustrates me. Look, I'm going bald as a result of it. Okay, this has nothing to do with genetics. I'm telling you right now, it has to do with arguing with people. They say that neutral postural alignment has nothing to do with anything in the spine. I'm like, really? Have you ever even looked at biomechanics studies whatsoever? They go, oh, there's no relevance for neutral posture. And then I'm like, well, why aren't we quadrupeds then? Why don't we just walk around like dogs and cats and cattle and sheep? There's probably a reason we walk upright. Do you get it? Now, if you alter neutral alignment, there's effects, and this is showing 4.5 times increase in the muscle activity required to maintain this position. There are consequences for that. Your muscles are going to fatigue. You're going to get spasm. It's going to increase the disc load. Look what happens to the disc compressive load. So here's the load in kilograms on the disc. Here's my neutral spine position, and then here's the increase that occurs in anterior translation. Like, look at that. Look at the load on the intervertebral disc. At L5S1, you've effectively almost doubled the load. Not quite, but you're almost doubling the load on the L5S1 intervertebral disc, which is where a lot of disc degeneration occurs. That's going to excite matrix metalloproteinases. That's going to cause a cascading effect, causing degradation of the disc tissue, causing back pain, etc. It starts with a biomechanical insult. The biomechanical insult is alteration of the alignment of the human thoracolumbar spine in this particular scenario. Hopefully I made myself clear. Now if we go back to the Kiefer et al. Study, how do their results equate to ours? They're actually pretty close if you look at the limits of their project versus what we did. They only translated the rib cage 40 millimeters forward. They got 550 newtons, which is 56.1 kilograms of force, acting on L5S1. You go back to our results, we're effectively not quite double the Kiefer et al. Results, but close. We're close to 100 newtons, but we're also double the amount of translation that they created. Different modeling studies, what you have to do is look at their limitations what their predictive equations were based on, and then their results. And then you can see that these two models actually have a close approximation in the two results, which is quite nice. It means that, number one, our results are reasonable, and number two, the Kiefer et al. Results are reasonable as well. Although we believe our model is a little bit better because it is actually based on real-life movements of the human thoracolumbar spine, not a constrained system. Okay, so then here's the shear loads in the spine. You can see the maximum shear loads actually occurred in the mid-lumbar spine. So at L2, L3, and L3, L4, that's where the maximum increase in the shear load from neutral to anterior translation occurred. Now you can see that the overall maximum shear load actually occurred at L5S1, but it's not as large of an increase at L5S1 as it is at L2, L3, and L3, L4, for example. And then the compressive stresses in megapascals, if you're interested in looking at that, at the different IVD levels, intervertebral disc loads. Again, it was greatest at the lower lumbar segments. So table 2 is interesting because it summarizes the percent change. And I do want to show one thing, even though we haven't talked about it. What's going on is you'll actually see an increase in muscle activity in the cervical spine as well. So if I look at the C2, C3, increase in the compressive stresses acting on this C2, C3 level, anterior translation of the thoracic spine has increased compressive stress by 12.4%. The muscle force at C2, C3 increased by 330%. Now, as a clinician, we see somebody, they come in with neck pain and headaches. It's my duty to try to figure out, is there a biomechanical reason that could be contributing to your neck pain and headaches? Now, if I see a position in your thoracic spine that is translated anteriorly in your posture and on your x-ray, if I know this information, I'm an astute clinician. I go, whoa, this position of your rib cage being forward, it's going to affect the upper neck muscle loads and disc loads. In fact, according to this model predictions that we have here in our 2005 paper, it's a 330% increase in muscle activity in your upper neck. Could that contribute to or cause headaches and neck pain? My belief is yes. I mean, you can have your own belief, but my framework is, hey, anything that's going to increase muscle activity is going to increase disc load. It's going to put pressure on some of the sensitive ligaments there. That's going to accentuate pain productive chemicals, and it's going to accentuate pain and disability, right? It doesn't take rocket science to kind of figure this out. Now, if you're a patient and you're at home, or you're a doctor, do this to yourself. Put your fingers in your upper neck area. Poke them in the back of the vertebral, of the facet joints at the mid and upper neck. So you come right to the muscles in the neck, and then translate your rib cage forward and feel what happens in that upper neck area. You're going to feel the muscles contracting there. Imagine what would happen if you go all day long, every day for several days or several weeks or several months. Could that lead to muscle spasms? Could that lead to pain? Could it lead to early degenerative changes? Could it lead to neck pain and headaches? My answer to those could be's is yes, I believe that that is true. Okay, that's my belief system. That's my framework. So what I'm going to do with that person is I'm going to take a patient, not only am I going to look at their neck, but I'm going to assess their entire spine. I'm going to take x-rays of their entire spine so I can see how this system's related. That's the difference in chiropractic biophysics technique. We don't just look at your point of pain. What you've got to realize is just because you hurt in the neck, it doesn't mean that that's where the main problem is. You may have a problem there, but it may in fact be driven by something else. In this case, anterior translation of the thoracic spine. Conclusion of this engineering project or this biomechanical study that we did, compressive loads on the anterior and posterior aspects of the disc, and by the way, I'm skipping some of the study, just the graphs are a little extraneous. We actually looked at overall average disc loads, and then we separated it into anterior and posterior components. So that's what this sentence means. The disc loads at L5S1, compressive-wise, nearly doubled in anterior translation. Anterior translation of the thorax resulted in significantly increased loads and stresses on the entire thoracolumbar spine. This posture is quite a common displacement in lumbar spine disorders. and could contribute to lumbar disc pathologies, progression of L5-S1 spondylolisthesis deformities. If you think about an anterior listhesis or a spondylolisthesis, if your rib cage is forward, it's increasing the muscle loads, it's increasing the compressive load, it's increasing the shear load acting at that segment. Could that accentuate the deformity? There's some evidence in longitudinal studies that say yes, that is absolutely true. Orthopedic studies have identified a 40 millimeter cutoff point for anterior translation of the trunk. If you go over 40 millimeters, you start to get more back pain, more disability, more neurological problems when you have a spondylolisthesis. This is likely related. And then I'm also going to say, so that's post-surgery, I'm also going to say it likely influences neck outcomes secondarily as well. Hopefully you enjoyed this week's research presentation. It absolutely does have relevance to different back pain, mid-back pain, deformity scenarios, and neck pain situations. If you understand the biomechanical loading of the spine, it opens up a clinical picture to where you can start to process why things might be occurring the way they are occurring in areas of a patient's spine that are actually removed from the displacement. If you look at biomechanics, it helps to address and answer some of these complex questions. Of course, it doesn't have all the answers. There's things that we don't understand with the human spine and pain processes and etc. yet, but this is one of the components of biomechanical displacement of the human thoracolumbar spine causing problems. If you're a patient out there, hopefully you struggled through this, hopefully you enjoyed my brief presentation here. Look for a CBP trained chiropractor. They understand the material that I've just went through. You can find a CBP trained chiropractor at my patient directory, www.cbppatient.com. You can find CBP trained chiropractors anywhere that we have them in the United States, Canada, Australia, the UK, Europe, etc. If you're a chiropractor and you want to learn more about this, go to idealspine.com and look up some of the information that's on there. Start the process of maybe attending a few courses and conferences with me. Love to have you on board with doing chiropractic biophysics technique. Patients out there need you. Also, if you would, please consider supporting our CBP Nonprofit Research Foundation. Without donations and without support, we can't do the types of projects that we do. We are a true nonprofit 501(c) corporation. We absolutely work on donations. We fund ourselves, but we also ask for funding from the outside members of the community, whether it's chiropractors or patients. Until next week, thank you for your time and attention.